Syndromes. So, physiologically, the heart conduction system starts from the SA node, which is located within the right atrium. After that, the action potential goes through the AV node, and from the AV node with a delay of about 0.1 seconds, it goes to the bundle of His, and after that into the right and the left bundle branches and to the Purkinje fibers. So the only electrical conduction is the AV junction. And technically, when there is an interruption within that AV junction, an atrioventricular block occurs. 0.5% of the population, they have an additional accessory pathway in addition to the AV junction. And in that case, the atria and the ventricles will be electrically conduction through two pathways, which is the AV junction and also the accessory pathway. And 10% of patients with an accessory pathway also have an additional secondary accessory pathway, which is often inactive. There are three main accessory pathways. The Kent's bundle, which is connecting the atria and the ventricles, and is creating Wolff-Parkinson-White syndrome. We have also James' bundle, which is connecting the atria with the His bundle, and it's creating LGL syndrome or lown Ganong levine syndrome. Mahaim fibers, they are connecting the atrioventricular junction and the ventricles, and it's creating Mahaim syndrome. So, pre-excitation syndrome, it means that the ventricles are activated earlier because they are pre-excited via the accessory pathway. And the most common accessory pathway is the Kent's bundle, which we said that it gives us Wolff-Parkinson-White syndrome. There are three pre-excitation syndromes that we talked about, and these accessory pathways, they conduct the impulses into the ventricles without delay, which is called non-decremental conduction. And the ventricles are activated earlier through these accessory pathways, leading to a pattern on the ECG, which is called delta wave, with a short PR interval. Let's talk about Wolff-Parkinson-White syndrome. So it's Wolff-Parkinson-White syndrome is associated with a small risk of sudden cardiac death. On ECG, we will have, as I said, a short PR interval, so it will be less than 120 milliseconds. We will have a delta wave, which is basically a slow rise of initial portion of the QRS. And we will have a discordance of ST segments and the T wave. Basically, it means the opposite direction of the major components of QRS complex, and pseudo-infarction pattern in up to 70% of patients due to negatively deflected delta waves in the inferior and lateral leaves producing pseudo-Q waves or prominent R waves in V1 till V3, mimicking a posterior infarction. The accessory pathway conducts impulses in three ways, in both directions, which is the majority of the cases, retrograde only away from the ventricles, about 15% of the cases, and anterograde only towards the ventricles, which is rare. So the direction of conduction affects the appearance of the ECG in sinus rhythm and during tachyarrhythmias. The accessory pathway can be either left-sided or right-sided, and ECG features will vary depending on this. So the left-sided one produces a positive delta wave in all the precordial leads, with R on S more than 1 in V1, and sometimes referred to as type A of Wolff-Parkinson-White pattern. Right-sided accessory pathway produces a negative delta wave in leads V1 and V2, and sometimes referred to as type B Wolff-Parkinson-White pattern. So, the features of this pre-excitation, they may be subtle or they may be present only intermittently, and pre-excitation may be more pronounced with increased vagal tone, for example during Valsalva maneuvers. There is also another type of pathway which is called concealed pathway. In these patients, there is a retrograde only accessory conduction, and all anterograde conduction occurs via the AV node. So there is no pre-excitation occurring, and therefore no features of Wolff-Parkinson-White syndrome are seen on the ECG in a sinus rhythm. But these patients can still experience tachyarrhythmias as the pathway can still form part of re-entry circuits. Tachyarrhythmias in Wolff-Parkinson-White syndrome can be of two types, either atrial fibrillation or flutter, due to direct conduction from the atria to the ventricles via the accessory pathway, bypassing the AV node. Or it can be an AVRT, atrioventricular reentry tachycardia, due to the formation of reentry circuits involving the accessory pathway. Now let's see some ECGs. So here we have, you can see here showed with the presence of a delta wave. We can see here on the precordial leads that there is a discordance between the QRS segments and the T waves. We can see the presence of a wide QRS complex, and we can see here on leads V1, we can see the presence of a tall R wave compared to S wave, which is normally different from a physiological ECG where the R wave progression will be slow from V1 till V6. So basically this one is a type A of Wolff-Parkinson-White pattern. Here we have a second example of Wolff-Parkinson-White syndrome. We can see here the presence of a short PR interval with delta waves are present. We can see the discordance is present as well, and we can see very tall R waves. Actually, this is mimicking left ventricular hypertrophy, but it's not left ventricular hypertrophy, it's just Wolff-Parkinson-White syndrome. Here we have another example. Here we have a deep S, which is present in V1, which means that it's type B of Wolff-Parkinson-White pattern. And we can see also some signs of left ventricular hypertrophy, but it's not left ventricular hypertrophy again, it's just Wolff-Parkinson-White syndrome, and it's mimicking left ventricular hypertrophy. This ECG is the same as showing Wolff-Parkinson-White syndrome, but actually here is different because it's a pediatric ECG. On V1 we can see a dominant R wave, but here we cannot determine if this pattern is type A or if it's type B, because actually in children normally on ECG they have dominant R waves on V1, so it's difficult to determine which pattern is it. So, for other pre-excitation syndromes, we have LGL syndrome, as we said before. It's because of presence of an accessory pathway which is called the James bundle. So, in this syndrome, we will have a short PR interval. It's the same thing, but we will have an absent delta wave because this accessory pathway is located so near from the His bundle, and it's like it's creating a normal conduction pathway. That's why we will have an absent delta waves on ECG. So the same ECG pattern is seen also in accelerated AV conduction. And to differentiate between these two conditions, electrophysiological testing is used. Here we have an example on the ECG. You can see a short PR interval, and we can see there is no presence of this slurring or delta wave. And here we have Mahaim syndrome. Again, it's because of presence of Mahaim bundle. So we will have a normal PQ interval usually, and we will have a presence of delta wave because it's away from the His bundle, and we will have a wide QRS complex. So usually for the diagnosis of these syndromes, electrophysiological examination is necessary to differentiate between them. Here on the ECG, if you notice well, we have a deep S in V1. Actually, it's mimicking a left bundle branch block. We have also an left axis deviation because it's mimicking the left bundle branch block because the Mahaim pathway is located within the right ventricle. And that's all for today. I hope this was useful.